We're going to continue looking at cardiac muscle. There are three differences from skeletal muscle that we've already looked at. About 1% of cells in cardiac muscle have automaticity. That means they have essentially the ability to create their own electrical current. These cells are called pacemaker cells. These are the autorhythmic cells, essentially. They can depolarize the entire heart by initiating an electrical signal that then spreads through the intercalated disc using the gap junctions. All the other cells in the heart that are not the pacemaker cells are considered contractile cells. They can contract, but they don't generate their own action potential. They can't create their own electrical energy. So we need both the pacemaker cells and the contractile cells for cardiac muscle contraction. The heart also contracts as a unit. What contracts as a unit are the cardiac muscle cells called the cardiomyocytes. And if the cardiomyocytes do not contract as a unit, none of them do. This ensures that the heart behaves in a functional syncytium, which is as one coordinated unit. They also have a long absolute refractory period. All cardiomyocytes have about a refractory period of 250 milliseconds. This is much longer than the refractory period seen in or for skeletal muscle, and this prevents the possibility of tetanic contractions, where essentially a contraction continues for so long that there's a type of paralysis. That would be very damaging a function for the cardiac system to use. There's also similarities with skeletal muscle. For example, depolarization still opens voltage-gated sodium channels. Those sodium channels still in the sarcolemma. It's still going to lead to a membrane potential shift that goes from a very negative to something more positive, usually about a negative 90 to a positive 30 shift. And then, after the initial brief depolarization, the sodium channels close very quickly. And then that depolarization will not only be generated in a particular part of the sarcolemma for cardiac muscle cells, it'll then go down the T tubules and still goes to the sarcoplasmic reticulum, allowing the release of calcium. There's still excitation contraction coupling, there is still a cross-bridge cycle, and calcium still binds to troponin, and that allows for the sliding filament mechanism of contraction. But there still are differences that we must acknowledge, and they're the ones that are probably going to be highlighted. The depolarization wave that opens calcium channels between the T tubules and sarcoplasmic reticulum are slow calcium channels. And the slow calcium channels are going to allow for the calcium surge in the cytoplasm to last a lot longer. It actually produces a plateau depolarization phase. And action potential and contractile phases last much longer for cardiac muscle. That's also going to allow for blood ejection from the heart. Then the repolarization is going to be a result of inactivation of these slow calcium channels and the opening of voltage-gated potassium channels. Calcium is still actively pumped back into the sarcoplasmic reticulum and is also pumped out of the cell from a few extracellular resources of calcium. So here we can see the action potential for contraction in cardiac muscle cells. We have depolarization, plateau phase, and then repolarization. So that plateau phase is new, and that's due to the influx of calcium from the slow calcium channels in the sarcolemma. And that's going to allow for calcium to stay in the cytoplasm longer than it would in skeletal muscle, and leads to this plateau phase before repolarization. We can also talk about how cardiac muscle has many mitochondria, and that's because it depends on aerobic respiration, or the quick production of ATP using oxygen. So it definitely needs oxygen for energy metabolism. It's not really going to carry out anaerobic respiration. Could it? Yes, but that wouldn't produce enough ATP to power the muscle of the heart. It'll readily switch fuel sources instead. It'll use whatever nutrient is available: fatty acids, proteins, amino acids. It would even use lactic acid from skeletal muscles. In the case that the heart cannot carry out aerobic respiration, then it will carry out anaerobic respiration. But it will also produce lactic acid. This is something seen in an oxygen deprived, essentially blood deprived, usually as well, cardiac myocyte. We call these cells that are blood deprived, thereby missing or lacking nutrients, ischemic cells. And their use of anaerobic respiration produces so much acid that we have such a high hydrogen ion concentration that it triggers the release of intracellular calcium from the sarcoplasmic reticulum. This premature release of calcium can also lead to mitochondrial damage. It can lead to gap junctions closing, and these can lead to things like decreased ATP production, which can be fatal to cardiac muscle cells, and fatal arrhythmias. Essentially, it can mess with the heart's rhythm or its beating. So the heart depolarizes and contracts without the nervous system stimulating it at all. We know this because cardiac myocytes have some automaticity. There's the pacemaker cells that are able to contract or stimulate an electrical signal called an action potential all on their own. Now, even though stimulation by the nervous system is not required, we still can alter the heart's beating, or when it depolarizes and repolarizes or relaxes and contracts, by using the autonomic nervous system. The autonomic nervous system can speed up or decrease the heart rate. The primary influencer of heart rate actually ends up being the parasympathetic nervous system, and it slows down the heart rate from about 100 beats per minute to about 75 beats per minute. The automaticity and communication with the nervous system also is going to rely on the presence of cell junctions, both gap junctions and desmosomes. The activity of the heart's in-house conduction system, called the intrinsic cardiac conduction system, also relies on these cell junctions. Gap junctions allow ions to pass from cell to cell, transmitting current across the entire heart. And desmosomes prevent adjacent cells from separating during contractions. The intrinsic cardiac conduction system is essentially just a network of those pacemaker cells, a network of those autorhythmic cells that can initiate and then distribute their own action potentials. And this is going to allow for coordinated depolarization and contraction of the heart. Now, we can't forget that the heart also consists of cells that don't generate their own electrical potential, that are not going to be pacemaker cells. Those are going to be the contractile cells that are going to take a signal from the cardiac pacemaker cells and allow it to travel not only to that system, but all throughout the heart. But the cardiac pacemaker cells make sure all of the contractile cells depolarize and contract in an orderly sequential manner. So without them, the heart would not contract. Autorhythmic cells have leaky membranes. That is what allows them to generate their own electrical potential. They essentially have an unstable resting membrane potential. It's kind of like a pre-potential. And the slow opening of sodium channels allows a slow depolarization that eventually reaches threshold. And when threshold is reached, calcium channels open. And an explosive amount of calcium coming inside during the rising phase of an action potential is going to allow for the firing of these autorhythmic pacemaker cells. Then they repolarize like normal. They'll have to inactivate the calcium channels and open voltage-gated potassium channels in order to reset back towards a more negative pole. So there's three parts for an action potential, especially those of the pacemaker cells. A pacemaker potential, which is going to be due mostly to slow sodium channels, which create an ion imbalance that gets close to threshold. Once threshold is met, we get depolarization, calcium channels open, and it's actually going to be a huge influx of calcium, not sodium, for the pacemaker cells that leads to the rising phase or depolarization. for these particular non-contractile cells. And then repolarization is going to be more normal. We have to shut off the calcium channels and open potassium channels. And we'll get an efflux of potassium. So here you can see the action potentials in pacemaker cells of the heart. There's a pacemaker potential, depolarization, and repolarization. The depolarization is due to an influx of calcium, not sodium. The repolarization is more normal. Cardiac pacemaker cells will pass impulses in a certain order across the heart. So not only can they generate their own electrical signal, they're going to do so in a certain order. It takes about 220 milliseconds. We start with the sinoatrial node, and then go to the atrioventricular node, followed by the atrioventricular bundle, also known as the bundle of His, the right and left bundle branches, and then the subendocardial conducting network, also known as the Purkinje fibers. The sinoatrial node can be abbreviated SA node, and it's known as the heart's pacemaker because it initiates the first impulse. The atrioventricular node can be abbreviated AV node, just like atrioventricular bundle can be abbreviated AV bundle. And then right and left bundle branches, that's pretty much their name regardless of the textbook. And subendocardial conducting network is a newer name, whereas Purkinje fibers is older, and you'll see it more commonly if you look up those particular parts. The SA node is located in the right atrium. It depolarizes the fastest, so it's going to generate an impulse at about 75 beats per minute. That's called the sinus rhythm. Now, it wants to generate an impulse at about 100 beats per minute, but the extrinsic factors that temper that impulse rate is the parasympathetic nervous system fibers, like the vagus nerve. It's known as the heart's pacemaker because it depolarizes the fastest and essentially starts off this intrinsic cardiac conduction system. No other region of the conduction system or the myocardium has a faster depolarization rate. From the SA node, the impulse or electrical signal will then spread across the atria to the AV node. Here you can see the location for the SA node, the heart's pacemaker. Next, we can talk about the AV node, also located in the right atrium, but on the right side of the interatrial septum. It actually slows down this electrical impulse coming from the SA node by about 0.1 second or 10 milliseconds. This slowing down or delay allows the atria to depolarize and contract before the ventricles, and that allows the ventricles to fill. So it's just going to make sure that the atria contract before the ventricles. We see that the fibers of the AV node are smaller in diameter. They have fewer gap junctions. And this allows atrial contraction prior to ventricular contraction and also slows or delays the impulse. So it's both a structural anomaly that allows for a functional process to occur in this sequence of excitation. And its inherent rate of contraction is about 50 beats per minute. And that would be what the heart beats at in the absence of SA node input. You can see here again, sinoatrial node, right atrium, closer to the septum, being covered by part of the pulmonary trunk. That is the AV node. The atrioventricular bundle, or AV bundle, is located in the top part of the inner ventricular septum. It is the only electrical connection between the atria and the ventricles. And the atria and the ventricles are not connected via gap junctions otherwise. So this is the only way to get a signal initiated in the right atrium down into the ventricles. There are other pathways that will take the electrical signal generated by the SA node and AV node into the left atrium. So here is the AV bundle, also known as the bundle of His. Right and left bundle branches are going to go down the interventricular septum towards the apex of the heart. And that impulse from the AV bundle will then make its way towards the bottom of the ventricles, or apex. Then the Purkinje fibers will go towards the outside walls of the ventricles, so they complete the pathway through the interventricular septum and out to the ventricular walls, and they are going to be the most elaborately branched. Now, they're going to be more elaborately branched on the left side of the heart, and that's because there's more myocardium in order to send signals to. And the AV bundle and the subendocardial connecting network, or Purkinje fibers, they depolarize or fire at about 30 beats per minute, and that's in the absence of any input from the AV node. Ventricular contraction would immediately follow the firing of the Purkinje fibers. So here you can see the Purkinje fibers primarily in the outer myocardium near the ventricles. We have a little bit more branching over on the left side because of the thicker myocardium that these branches need to serve. And this cardiac conduction system would send this electrical signal out from these 5 parts to the contractile cells, allowing the entire heart to beat as a unit. So the SA node generates the impulses. It's the heart's pacemaker. The AV node delays the signal by 0.1 second or 10 milliseconds. That makes it, in a way, the heart's gatekeeper. That makes sure that the atria contract completely and the ventricles fill. The AV bundle in the superior interventricular septum connects the atria to the ventricles. The bundle branches carry the signal to the end of the interventricular septum at the apex, and the Purkinje fibers, or subendocardial conducting network, depolarize the contractile cells of both ventricles. You can see here in this image, the SA node fires first, or has the initial depolarization, which makes it the heart's pacemaker. We can also talk about some homeostatic imbalances, like defects in this intrinsic cardiac conduction system, like an arrhythmia, an irregular heartbeat. That would be caused by uncoordinated atrial and ventricular contraction. An example is a type of fibrillation, which is rapid irregular contractions, which are useless for pumping blood, would cause circulation to cease and could lead to brain death. Control of heart rhythm would then most likely have been taken away from the SA node, and that would produce kind of this back and forth contraction of different parts of the heart, which would kind of look like a squirming bag of worms. A treatment for fibrillation, a type of arrhythmia, is defibrillation, essentially using paddles to electrically shock the heart with the idea of wiping the slate clean and with the hope the SA node will be able to take over again as the heart's pacemaker. A defective SA node, though, could cause an ectopic focus, and that's when you have a different pacemaker, an abnormal pacemaker. The AV node may take over. That would set a junctional rhythm of about 40 to 60 beats per minute, and that's adequate to maintain circulation. Or maybe because of high intake of caffeine or nicotine, you have an ectopic focus that's going to set a higher rate than what we see for the SA node. That's known as extrasystole, and it's premature contraction. It could be from excessive use of certain drugs, again like caffeine or nicotine, but an ectopic focus that causes extrasystole is always going to generate an impulse more quickly than the SA node. And remember, to reach the ventricles, the only method is to have an impulse pass through the AV node, then onto the AV bundle, because the AV bundle is the only connection to the atria and the ventricles. So if you have a defective AV node, we can't get anything to the AV bundle, and that could cause heart block. There are different types of heart block, partial or total, and with few or no impulses reaching the ventricles, it may lead to the ventricles to be at their intrinsic rate, and their intrinsic rate is too slow for life. A treatment for this is an artificial pacemaker, and that recouples the atria to the ventricles. Don't forget that the heartbeat is modified by the autonomic nervous system. That the sympathetic nervous system, the accelerator, would increase heart rate and increase the contractile force, whereas the parasympathetic nervous system would slow heart rate and decrease contractile force. And it's really the vagus nerve of the parasympathetic nervous system that brings down the inherent heart rate from about 100 beats per minute to 75 beats per minute, called the sinus rhythm. We can find neuron nuclei in the medulla, and these areas in the medulla are called the cardioexcitatory center and the cardioinhibitory center. The cardioexcitatory center is associated with sympathetic nerve fibers, and therefore it can affect the sinoatrial node, or SA and AV nodes, heart muscle, and coronary arteries. The cardioinhibitory neurons can do a similar thing. They are going to communicate with the parasympathetic nervous system, be located in the cardioinhibitory center, and they cannot stimulate but inhibit the SA and AV nodes, and they're going to use primarily a vagus nerve. A vagus nerve is a really large parasympathetic nerve, also known as a cranial nerve. So here you can see some of the innervation of the heart. So here is part of the brainstem, the medulla specifically. Note that the cardioinhibitory and cardioacceleratory centers are located in the medulla oblongata, and they'd be able to send signals down the spinal cord to the heart. They would use either sympathetic or parasympathetic nervous system fibers. So here the vagus nerve in purple is the sympathetic nervous system fiber, and the green fiber here is the sympathetic nervous system fiber. And again, sympathetic nervous system is known as the fight or flight system, so it can increase heart rate and contractile force, whereas the vagus nerve of the parasympathetic nervous system primarily does the opposite, like decrease heart rate. We can also look at an ECG, also known as an EKG. It's a composite of all the action potentials generated by nodal and contractile cells at a given time. Nodal cells is another name for the pacemaker cells. Each wave or piece of an ECG or EKG corresponds to a certain event of the cardiac electrical cycle. There's three main waves, though, that we want to know about: the P wave, QRS complex, which is a series of waves, and the T wave. The P wave is indicative of depolarization of the SA node, and when the SA node depolarizes, that depolarizing signal causes atrial depolarization, which leads to atrial contraction. The QRS complex is associated with both ventricular depolarization and atrial repolarization, so it's associated with both ventricular contraction and atrial relaxation. And the T wave is associated just with ventricular repolarization or relaxation. So here we can see a base EKG, or a normal electrocardiogram. You can see the P wave, QRS complex, and the T wave. We could also look at the segments, but we want to focus on the waves. First, the atria contract. That's atrial depolarization. Then the ventricles contract at the QRS complex. And then the ventricles relax at the T wave. You may be wondering, well, when did the atria relax? Also during the QRS complex. And that is why the QRS complex is associated with the ventricles depolarizing or contracting and the atrial repolarizing or relaxing. So again, at the P wave, the atria depolarize. That signal is going to be initiated by the SA node. It not only causes the P wave, but leads to a contractile force spreading through the atria. As the atrial depolarization completes, the impulse will be delayed at the AV node right before the QRS complex. Then we will have the signal go from the AV node to the AV bundle, and that will begin ventricular depolarization. That's going to initiate the QRS complex, and the atria during this stage are relaxing as the ventricles are beginning to depolarize. When ventricular depolarization is complete, the signal will have traveled all throughout the ventricles, including towards the apex and out towards the outer ventricular walls. Then we will see the ventricles start to relax as the T wave is caused. This is due to a wave of repolarization, and ventricular repolarization begins at the apex, and that causes the T wave and essentially kind of moves up like a tube of toothpaste from the apex upwards. And as ventricular repolarization is complete, the EKG ends. So note, we have the atria contract and then relax. Then the ventricles contracts and then they relax. So this back and forth contraction and relaxation is seen thanks to the intrinsic cardiac conduction of the heart, making sure the signal follows a certain path, and that ensures that the heart beats as a unit or in functional synctium. Now, a normal ECG tracing is like what we see here at A, but there's some modified or abnormal tracings, like a junctional rhythm or second-degree heart block or ventricular fibrillation. A junctional rhythm is when the SA node is non-functional. Nope, you really only see a QRS complex and a T wave. So the SA node depolarization is completely absent. P waves are missing. Here with second-degree heart block, you may have some P waves, but most of them are not conducted through the AV node. So you have a lot more P waves than QRS waves. So we really see small QRS complexes, and they're actually not big enough to consider them true QRS waves. And then here is ventricular fibrillation, and this is not organized at all. This is very chaotic. It's a really irregular ECG, and it's seen because of an acute heart attack here and electrical shock. The idea of using electrical shock, though, should wipe this clean and hopefully return us back to normal sinus rhythm. So again, make sure that you know what occurs at the P wave, QRS complex, and T wave. We can also look at the heart sounds, and there's two sounds, a lup-dup or S1 and S2. They're associated with the closing of heart valves. The S1 or lup sound is associated with the closure of the AV or atrioventricular valves. This is at the beginning of ventricular systole, meaning the ventricles are beginning to contract and they push the AV valves close as blood hits the underside of these valves. The second sound, or S2, also known as the dup sound, is associated with the closure of the semilunar valves. This is going to occur at the beginning of ventricular diastole. After ventricular ejection, the ventricles start to relax, but that blood has moved past the semilunar valves and rebounds or bounces off of the top side of the semilunar valves, making the sound. There's a pause between the lup, dup, or S1 and S2 sound, and this pause indicates the heart relaxation. If there's a heart murmur, that's an abnormal heart sound. That usually says something's wrong with a valve. Maybe it's incompetent or stenotic or there's backflow. It might be failing to open completely or restricting blood flow. Here are the areas where you would hear sounds of the individual heart valves. For example, the pulmonary valve, it can best be heard with a stethoscope between the second intercostal space at the left sternal margin. The mitral valve can best be heard over the heart apex, and that's about the fifth intercostal space, and that's going to be about in line with the middle of the clavicle. The sternal margin of the fifth intercostal space, just a little to the right of that, great place for the tricuspid valve. Aortic valve should be heard close to the second intercostal space at the right sternal margin. Next, we're going to talk about the cardiac cycle. And the cardiac cycle is looking at blood flow through the heart during one complete heartbeat. So it's going to include atrial systole. Remember, systole is similar to contraction, and atrial diastole. Diastole is similar to relaxation. That, of course, will be followed by ventricular systole and diastole. So we're going to be looking at the atria contract and relax, and then the ventricles contract and relax. Remember, when the atria are relaxing, the ventricles are contracting. But there will be a period of time when the atria and the ventricles, for a moment, are both in diastole or relaxing. The cardiac cycle can be depicted as a series of pressure and blood volume changes as the blood flows through the heart. We begin with ventricular filling, and this is a passive state. It occurs when both the atria and the ventricles are in diastole. They're both relaxed. All the AV valves are open, the tricuspid and the mitral, and blood's coming back to the heart, entering the atria, and then passively flowing into the ventricles. About 80% of blood just passively flows into our pumping chambers, or the ventricles. And then the heart will start to contract. The atria first enter systole. They will deliver the remaining 20% of blood that was flowing back to the heart into the ventricles. After the atria contract, the ventricles will start to contract when they're relaxing. And as they contract, they will not yet open the semilunar valves, and that will produce a volume in the ventricles that for a moment is not going anywhere. And this volume is known as the end diastolic volume. And it's the volume of blood in each ventricle at the end of ventricular diastole. So this is after the atria contract and right before the ventricles are about to contract. As the ventricles move into systole, as they begin to contract, the atria are relaxing. There's going to be rising ventricular pressure that pushes the AV valves closed. But until there is enough pressure to push open the semilunar valves, there will be a moment in time during ventricular systole when all valves are closed. This phase of ventricular systole is called the isovolumetric contraction phase. It will leave essentially very quickly into the ejection phase, where ventricular pressure exceeds the pressure needed to push open the semilunar valves, and then blood will be ejected into major arteries. Once all the blood leaves the ventricles, but before the AV valves reopen, you'll have a certain volume of blood. This volume of blood, called the end systolic volume, should be less than the end diastolic volume. This is essentially the volume after the heart has ejected blood from the ventricles. So it's the volume of blood remaining in each ventricle after systole. Isovolumetric relaxation will follow because after the ventricles contract, they relax. This is early diastole for the ventricles. And the atria at this point are relaxed already and filling with blood. But there's not enough pressure in the atria to push open the atrioventricular valves, or AV valves. And the semilunar valves have closed after ejecting blood, so for a moment in time, again, all of the valves are closed. There will be a small backflow of blood in the aorta and the pulmonary trunk, and that's what closed the semilunar valves. You could see this on a graph, and this particular location on a graph showing this pressure is called the dicrotic notch. It's a brief rise in aortic pressure as blood rebounds off closed valves. The ventricles, again, at this point during the isovolumetric relaxation phase, are totally closed chambers. Both the atrioventricular and semilunar valves are closed. But again, when the atrial pressure exceeds that in the ventricles, essentially blood's pulling into the atria and it pushes these AV valves open, we'll begin again at step 1. So again, step 1 was ventricular filling. Both the atria and ventricles are relaxed. Then the atria contract, push the rest of the blood into the ventricles. As the atria then relax, the ventricles begin contracting. This is the isovolumetric contraction phase, and in any isovolumetric phase, all the valves are closed. Here you see that we're beginning to squeeze the ventricles, but there's not enough pressure to push these semilunar valves open. So there's contraction, but for a moment, the volume stays the same in the ventricles as it was at the end of atrial contraction. This volume here is also known as the end diastolic volume. Then the pressure builds up enough to eject blood into the major arteries. This is the ventricular ejection phase, and these are the two phases of ventricular systole. When the ventricles are contracting, the atria are relaxing or in diastole, and the ejection phase will give way to the isovolumetric relaxation phase, where there's not a lot of blood, if any, left in the ventricles, and then there's blood rebounding on the semilunar valves up top, keeping them closed. As the isovolumetric phase, all valves are closed, and for a moment in time, the volume of blood that's in the ventricles remains the same. And here is the end systolic volume. So end diastolic volume is a bigger volume of blood, or should be, than end systolic volume. And then as the atria fill with blood, eventually there'll be enough blood in the atria as the blood returns to the heart that it'll push open the AV valves. That will begin ventricular filling, and we're back at step 1. Cardiac output can look at the volume of blood that's being pumped by each ventricle in 1 minute. Cardiac output and stroke volume are really similar, because stroke volume is volume of blood pumped out by one ventricle with each beat. The difference is cardiac output has a time portion. It is actually stroke volume times heart rate. And since heart rate is number of beats per minute, that's where we're getting the time interval. So cardiac output can be calculated by multiplying heart rate times stroke volume. We're talking about cardiac output after looking at the cardiac cycle because we were looking at not only the ventricles filling, but them having a certain amount of blood that they then eject into the major arteries. And that essentially is cardiac output. You can increase cardiac output if you increase stroke volume and heart rate. Maximal cardiac output is generally about 4 to 5 times the resting cardiac output in a non athletic person. Maximal cardiac output, though, may reach 35 liters per minute in a trained athlete. And there is a cardiac reserve, or a difference between resting and maximal cardiac output. So, in order to get stroke volume, which is the amount of blood ejected from each ventricle in one heartbeat, you have to take EDV, or end diastolic volume, and subtract ESV, end systolic volume. So, essentially, you're taking the largest amount of blood that's in the ventricles during the cardiac cycle and subtracting what's left over at the end of ventricular ejection. EDV can be affected by the length of ventricular diastole and venous pressure. Because if ventricular diastole or diastole is very long, that means the ventricles fill with more blood, and that will stretch the ventricle walls, and that will lead to more blood during the isovolumetric contraction phase. In ESV, we primarily see what affects that is arterial blood pressure and the force of ventricular contraction, because if the force of ventricular contraction is very strong, it can eject more blood during ventricular ejection. If more blood is ejected into the major arteries, it's not in the ventricles, and that will lower ESV. There's 3 main factors that affect stroke volume by essentially affecting EDV and ESV. Preload, which is the degree of stretch of the cardiac muscle cells, looking at them primarily before they contract. This works based on a law called the Frank-Starling law of the heart. Essentially, we're looking at cardiac muscle cells and their length-tension relationship, because at rest, cardiac muscle cells are shorter than their optimal length. And that's the most important factor when it comes to stretching cardiac muscle cells, because venous return, or the amount of blood returning to the heart, can take them past their optimal length and stretch them even further, extensively kind of stretch them like a rubber band. And the more you stretch this rubber band, or cardiac myocyte, the more likely it is to use more force in order to get back to its optimal length. And a slow heartbeat, exercise, all that can increase venous return, or the amount of blood entering the ventricles, and causing more stretch. So increased venous return distends or stretches the ventricles and increases the contraction force. More stretch, more contractility. Contractility is another thing that regulates stroke volume. The contractile strength at a given muscle length is independent of muscle stretch and EDV. There's other chemicals that can affect contraction force, such as sympathetic stimulation, which causes increased calcium influx and more cross bridges to form, or the use of positive inotropic agents like thyroxine, glucagon, epinephrine, high extracellular calcium levels. These would all increase contraction force. There's also going to be negative inotropic agents like increased extracellular potassium, acidosis, calcium channel blockers that would decrease contractility. Here we can see norepinephrine increasing heart contractility using a second messenger system, where the second messenger is a cyclic AMP or CAMP signaling molecule, which will turn on protein kinases, and that will allow for phosphorylation of the sarcoplasmic reticulum calcium pumps, speeding up calcium removal and relaxation, making calcium more available for release on the next heartbeat. It can also increase intracellular calcium release. And again, this is all using a second messenger system that begins with the first messenger, the hormone, binding to a receptor, activating a GTP, and then having that go talk to an enzyme like adenylate cyclase, which uses ATP to make cyclic AMP. And that's what turns on inactive protein kinases. And there's also afterload, which is the pressure in the ventricles that they must overcome to eject blood. Afterload is actually looking a lot at high blood pressure. Hypertension increases afterload. There's a lot of pressure in the arteries, then more pressure is needed by the heart myocardium in order to eject blood. If hypertension is very high, then that can actually increase ESV. It can make ventricular ejection not very successful and lead to a lot of blood pooling in the ventricles even after a heartbeat, and that reduces stroke volume. We can also talk about the regulation of heart rate. Just like we had inotropic agents, there's also positive chronotropic and negative chronotropic factors. Now, instead of looking at contractility, chronotropic factors are looking at heart rate. Positive chronotropic factors increase heart rate, whereas negative chronotropic factors decrease heart rate. And the sympathetic nervous system Also, when activated, can increase heart rate. It can be activated by emotional or physical stressors. And norepinephrine is a common neurotransmitter it uses, which causes pacemakers to fire more rapidly. When they fire more rapidly, they can also lead to, or it can lead to, increases in contractility. Norepinephrine generally binds to beta adrenergic receptors in the heart, allowing for an increase in heart rate. An increase in heart rate can lead to increased contractility, which, if it's contracting faster, it will relax faster, which can offset a lower EDV, allowing essentially to a decreased fill time. Essentially, it's making up for low EDV by contracting more, ejecting more, so there's more likelihood to get the blood faster into circulation. There's also going to be input by the parasympathetic nervous system. It primarily opposes sympathetic effects, primarily uses the vagus nerve to associate or relate information to the cardiac muscle. It would use primarily acetylcholine to hyperpolarize the pacemaker cells by opening potassium channels and leading to potassium efflux, slowing down heart rate. It doesn't really affect contractility, and the heart at rest exhibits primarily vagal tone using sympathizing types of neurons, and those neurons are going to have a primarily parasympathetic dominant influence. Autonomic nervous system regulation also includes the atrial or vein bridge reflex, and this is a sympathetic reflex initiated by increased venous return, and that's going to cause increased atrial filling. Increased atrial filling is going to stretch the walls of the atria, which stimulates the SA node, leading to increased heart rate. It also stimulates atrial stretch receptors, activating sympathetic reflexes, and this prevents pooling of blood in the venous system. So here is a chart looking at the factors involved in determining cardiac output. And so essentially we're also going to be looking at things that affect stroke volume. So when we're talking about cardiac output, we know stroke volume and heart rate are the two things we multiply together to figure out cardiac output. And cardiac output is the amount of blood pumped from the ventricles per minute. Stroke volume is the amount of blood pumped by the ventricles per heartbeat, and heart rate is how many times the heart beats per minute. If you increase stroke volume or heart rate, you're going to increase cardiac output. We generally see that an increase in heart rate is caused by increased sympathetic activity, whereas an increase in parasympathetic activity would decrease heart rate. But if you increase sympathetic activity and decrease parasympathetic activity, we can increase heart rate and increase cardiac output. Increased sympathetic activity can increase contractility. Contractility can also be increased by the use of positive inotropic agents like epinephrine, thyroxine, increased calcium influx. And that is going to bring down ESV or end systolic volume because increased contractility makes ventricular ejection more successful, leading to an increase in stroke volume or the amount of blood leaving during ventricular ejection. We can also note that a lower heart rate allows more time for ventricular filling, and that leads to increased venous return. And if you have more blood returning because of a decreased heart rate to the heart, and it has more time to not only get into the atria but into the ventricles, you're adding more blood to the ventricles per heartbeat, which is an increase in preload, which is essentially the same thing as EDV or end diastolic volume, and that can increase stroke volume. And increased EDV is oftentimes associated with decreased ESV if we're going to have an increased stroke volume. You can increase venous return also by exercise. Exercise will stimulate the sympathetic nervous system, but also skeletal muscle and respiratory pumps to help get blood back to the heart and increase venous return and affect EDV, which affects stroke volume. This is a good chart to come back and review. So looking at hormones that regulate the heart rate, primarily epinephrine and thyroxine, they tend to enhance effects of other hormones and/or attack parts of the adrenal medulla and increase heart rate and contractility, turning on the sympathetic nervous system. Use of calcium, whether it's from intra or extracellular sources, is also going to be vital for maintaining a normal heart function. Some other homeostatic imbalances that could affect heart rate and heart function are hypocalcemia, which is a low amount of calcium. It can depress the heart. Hypercalcemia, a high amount of calcium, can increase heart rate and contractility. Hyperkalemia alters electrical activity of the heart, can lead to heart block and cardiac arrest. Hyperkalemia is an increased amount of potassium. Hypokalemia is not enough potassium and can lead to a feeble heartbeat and arrhythmia. So while potassium can inhibit heart activity, you do need a certain amount of it to allow for repolarization and reset. You don't want too little. Other factors that influence heart rate are age. A fetus has the fastest heart rate. Gender. Females have a faster heart rate than males. Exercise increases heart rate. And body temperature. Increases in body temperature are associated with increased heart rate. So body temperature, exercise, gender, and age are all other factors that influence heart rate that are not those we talked about that have to do with cardiac output. Other homeostatic imbalances are things like tachycardia and bradycardia. Tachycardia is an abnormally fast heart rate, which is over 100 beats per minute. This can lead to fibrillation or problems with a heartbeat. Bradycardia is a heart rate slower than 60 beats per minute. It can be a result of grossly inadequate blood circulation in non-athletes, but oftentimes a low heart rate is desirable, especially if you've been doing endurance training. Congestive heart failure is abbreviated CHF, and this is a progressive condition. It doesn't have a cure. Primarily, you treat the symptoms. It primarily reflects a weakened myocardium that's caused by coronary atherosclerosis or clogged arteries, persistent high blood pressure, multiple myocardial infarctions or heart attacks, and a dilated cardiomyopathy or DCM, an enlarged heart. What occurs is you have cardiac output so low that blood circulation is inadequate to meet tissue needs. So some tissues aren't getting enough oxygen. You might have blood pooling in certain areas. You don't have enough pressure in order to get that blood back to the heart. So there's a whole host of issues. With pulmonary congestion, the left side of the heart fails and the blood backs up in the lungs. If there was peripheral congestion, the right side of the heart fails and the blood would then pool in the body organs. Occasionally there's a little bit of both. That's a very dangerous type of CHF and generally is most fatal. Edema can occur when blood pools in body organs, essentially swelling because of the blood pooling, but failure of either side ultimately weakens the other, and it's primarily treated again by just removing fluid, reducing afterload, or handling and treating hypertension and increasing contractility. So we can treat the symptoms, but there's no cure for CHF. And that is it for part B, looking at the cardiovascular system. Next, we're going to look more at that vascular side and look at blood vessels.